Okay, thank you very much, dear our participants. It's our pleasure today to have a presentation from Dr. Derek Mahony, Australia. I think he's a well-known figure in orthodontics. He has influenced the orthodontic teaching in the last decade, and he is the founder of the full face orthodontics. It's a new concept for, I think, for the Egyptian students at least, and it's a marvelous concept, and you can follow him on Facebook pages as well as his website. I think all of us, Dr. Derek, waiting for this lecture today. It's too early morning here in Egypt, but we are happy to be with you, benefiting a lot from your experiences and expertise, and we are happy, more than happy to welcome you in Egypt. We are hoping to meet you in Egypt in our conference that will be held in 2021. It's our pleasure, and we are grateful for you. Thank you for this chance, Dr. Derek, and we are appreciating your valuable effort. Thank you very much again and again. You can start now your webinar. Thank you.
Okay, thank you. So what I want to discuss tonight is a new way of looking at Class 2. I did classical training many years ago at the Eastman Hospital, where Class 2 was always viewed along the lines of SNA, SNB, and very much AP changes to the maxilla or mandible or both. I guess after many years of being in practice, what I notice is that a lot of Class 2 correction is more based on transverse problems and secondly, vertical problems. And I'll explain that as I show you some cases tonight. So in my vertical growing Class 2s, I'm doing molar intrusion to encourage auto-rotation of the mandible. So even though we see and measure an AP change, the mechanics are more molar vertical. In the low angle Class 2s, if I'm managing in a growing individual and I translate the mandible forward, then the stability is based on molar extrusion, again, a vertical movement. And I want to mention the work of Jim McNamara that talks about preparing the maxilla for the mandibular advancement, which is a transverse movement, right? So even though we measure for diagnosis and to measure success of our Class 2 using AP correction, we tend to mechanically do more transverse and vertical changes to the jaw. Now, I just want to check why this is not advancing. So I have a short time with you today, but these are the topics I want to touch on. Number one, if you advance the mandible, as Jim McNamara calls functional appliances, do they really work and what's their literature as far as long-term stability? And secondly, when do I advance the mandible? When do I advance the mandible surgically? When do I treat non-surgically? And this is very much based on a measurement from condylean to gnathian, the mandibular length. A lot of the adults I will show you tonight have a normal mandibular length. And if you look at the excellent paper by Dr. Yu, and I'll show you that paper in a minute, he showed when he did the cephalometric measurements of mandibular length in Class 2 and Class 1 individuals, the majority of Class 2 individuals actually had a Class 1 mandible. So I teach my students that if you have a normal mandibular length and a retrognathic mandible, then that treatment plan will be different to someone who has a micrognathic, or in other words, a small mandible. Small mandibles, if you can work with growth and you look at the excellent research of Frankie and Barchetti McNamara, and you look at the post-pubertal growth spurt of the craniofacial complex, that's the time where we can do some changes. But even after that, when growth is nearly complete, if mandibular length is normal, you can reposition the mandible. So that brings me on to my next topic, which is timing of treatment. You know, do we have to treat during growth? I see many places around the world, some of the Class 2 treatment is started too early, and that compromises the stability. And then the last thing I want to share with you is how I went from traditional training using retraction-based appliances. So I viewed every Class 2 as a maxillary problem, to now understanding that for class 2 mandibular problems, I can use either fixed or functional appliances. And I want to compare and contrast the differences. And I started originally doing a bionator type treatment in growing children. I then was exposed to the excellent work and research of Dr. Bill Clark, and I moved to twin block appliance therapy. Nowadays, I use fixed functionals, and I use mainly the MARA, which stands for Mandibular Anterior Repositioning Appliance, or the newer version of the Herbst. The traditional Herbst you may be exposed to, or the Herbst CBJ. The newer version is a miniaturized version. It's called Advanced Sync, and Dr. Terry Dischinger in the USA has done a lot of work with this appliance, and both of these are very good choices if compliance is an issue. Then what happens once you bring the mandible forward? What keeps it there? What stops it dropping back? And that's where I'll discuss a little bit about case finishing and stability associated with that, right? So I think the old saying was, the earlier you treat, the more the face adapted to your treatment. Whereas if you waited until your facial growth was complete, you then had to do compromise or camouflage so that your mechanics tried to fit the face. So I try and teach my students, and the way I practice and the way I lecture, it's called full face orthodontics. To me, it is as important to have a balanced facial profile as it is to have straight teeth. And I like the new version of Prophet, which is basically rewritten by Dr. Sava, because Sava has put a greater emphasis on this concept, on smile arc, on soft tissue, on nasolabial angle. You know, we plan now many times our finishes based on that and based on changes, what Sava calls the fourth dimension of the face, which is the changes as you get older and growth, right? So we talked a bit about passive self-ligation, and I think with modern technology and the use of TADs, you can practically move teeth anywhere. I mean, I think that's not where the skill of the orthodontist should lie. I think the skill of the orthodontist should now be to move the teeth into what balances the face and improves the airway. And that's what I built my foundation and philosophy on. So, you know, at the Eastman Hospital, class 2s, I mainly use headgears. I use high pull or low pull based on the vertical direction. Right? And this then concluded with, back then my training was in standard edgewise and a lot of class 2 elastic, right? When I graduated from the Eastman, I spent some time in Europe. I learned a lot about airway with my research at the Karolinska Institute with Professor Sten Linde Aronson. And I was exposed to what I call European orthodontics. And European orthodontics was vastly different to English orthodontics. And I'm saying that because obviously I have a training for my undergraduate in Australia. I have my postgraduate degree in the UK, but I do a lot of my research in Europe, and my PhD is University of Barcelona. So the Europeans are very used to what's called functional jaw orthopedics. And functional jaw orthopedics is the keystone of fixing airway problems in growing children. And maybe in future, I will give you a specific lecture on pediatric OSA and the role of the orthodontist, because that summarizes my emphasis in clinical practice in the last 15 years. This is my 34th year in clinical practice. And I can tell you I've moved from class 2 correction, which involved tooth movement, to more functional work. And I've changed my functionals from removable appliances because of compliance issues to more fixed appliances, okay? And I've changed my surgeries, for those who still need the surgery, to a less aggressive surgery known as an IMDO. So I very rarely do a full BSSO now for my class 2s. We use distraction techniques. I very rarely do a full Lefort for my narrow maxillas. We use what's called dome. So dome is distraction osteogenesis for the maxilla. IMDO is distraction osteogenesis for the mandible. And again, I'm able to use these techniques at the appropriate age to get very, very nice outcomes. So I hope maybe at the end of my lecture tonight, you may think a little bit differently about class 2, what causes it, how we would address it, you know, et cetera, et cetera. And there are many ways to camouflage class 2. This man has severe sleep apnea. And when he presents for orthodontics, if you're not aware of that, you may view his treatment based around cephalometrics, based around your norms that you were exposed to in orthodontic school, right? But if you add to the mix his airway, he is biskeletal obtrusive. So he really needs both his maxilla and mandible advanced, but it's a harder thing to do at this age. Not impossible, but a lot more work. Or if you camouflage, you could retract his upper incisors, which would not help his airway, or you could disguise his class 2 with a genioplasty, and in this case, possibly asking him to grow a beard. Now, all of those will help the soft tissue profile. And this is something I pulled off the internet just before the lecture. You can see this is a Pierre Robin type profile. And if he became a hipster and was to grow a thick mustache and a thick beard, he looks better. Why does he look better? Because his real problem lies from his nose down. You know, his maxilla and his mandible are not in the correct position. So I think when I use the term class 2, since the days of Angle, class 2 has really been either a combination of upper retraction, lower protraction, or various modalities that focus on one versus the other. So I want to share with you tonight what modalities will give you more orthopedic change, more skeletal, less dental. What is the difference between a bite jumper and a functional appliance? What is the difference between class 2 elastics in reducing an overjet versus combining overjet reduction with jaw correction? Because all of this is decisions we need to make. So when do I still use headgear? I use Toysha mechanics with J-pull modified headgear in a growing VME. A high angle class 2, we want to try and prevent that maxilla from downward growth and the mandible from retrognathia. Other than that, I no longer use what I was taught in orthodontic school, which is the classical technique where we try and restrain growth of maxilla to let the mandible catch up in class 2 correction, right? And there's a reason for that, and most of that's based on what I've seen with side effects of headgear, whether it comes from increased risk of the face bow coming loose and retracting back to the eye, when it comes to chiropractic problems with the pressure or anchorage of these headgears on the cervical vertebrae, et cetera, et cetera. So, you know, I've gone from a philosophy of training, which I would call my traditional orthodontic background, which discuss restraint of the upper jaw, to now looking at arcular analysis. Now, if you go to my YouTube channel, there's many free videos, and one of them I like you to watch if you haven't been exposed to arcular classification is the lecture I've done with Dr. Josh Jefferson. And this is called the Jefferson analysis. And the Jefferson analysis allows me to look at the maxilla and mandible, not just in relationship to each other, but in relationship to the anterior cranial base. So if we understand growth and development, we understand that in the growth of the craniofacial complex, the synchondrosis, or the primary growth centers, of which anterior cranial base is one, probably finishes very early in life, by 7. And then by 7, you have most of your maxillary growth, what we call the vertebral stages of CVM 1 and 2, right? And then after that, only after that, you start seeing the mandible change. And at the end of facial growth, which for the average individual would be 12, ideally the maxilla and the mandible should be in a forward position relative to the cranial base. And this is where Sassoon, Beizell, and the Jefferson analysis come in. So getting back to my PhD research, the patients who had the worst airway, so nothing to do with the degree of overjet, degree of crowding, facial profile, nothing like that, but purely measurement of their airway. The worst airways, the most collapsed airways, were the people who had what's called BR, where both the maxilla and mandible were retronated. And if you added to that a long face, this is what I like to call a class 4 malocclusion. Class 4 means biskeletal retrusive vertical. And that is absolutely a predictor for airway-related problems in individuals, right? So what I'm suggesting that we do in these individuals is look at balancing their airway, balancing their face as part of our orthodontic care, right? So a 2A, which is a normal mandible, but a protrusive maxilla, you could still use conventional mechanics, and I do for that. That's the cases where I'm doing restraining of the upper arch. I may be extracting upper bicuspids, etc. But a 2B is more the patient that I'm minimizing my retraction. And I do some combination therapy in the 2Cs. A 2C for me in practical terms would be very much a carrier motion appliance type case, right? Whereas a 2B is for me a MARA or advanced sync. A 2A for me is, depending on the severity, purely upper distalization using something like a K-loop or a pendulum appliance, etc. Right? So this is what we look at in these different individuals, right? So then when I discuss maybe in a future lecture the class 3s, the most airway problems in class 3s are maxillary deficient. So normal mandible, but mid-face deficient maxilla. So in order of priority, when I did the airway on kids at least, children who were biskeletal retrusive or 2B or 3A were the highest tendency to have the apneic problem. So let's keep that in mind as we look at things. So, you know, many students, and I see a lot on the internet, cases being presented purely with the use of photographs and study models without any cephalometrics, without any airway measurement, without any CBCT. And it's very hard to give a proper diagnosis. So if all you think about is teeth, you could look at this case and you can say, right, I have an increased overjet, I have a class 2 buccal segment, and I have crowding, no room for the canine. If I simply extract upper bicuspids, I can end up with all the ideal 6 keys that Andrews has discussed. But have I done that in the right face? And this is the question we need to ask ourselves, right? So in my practice, if I have someone who has airway-related issues, and I trace them up as biskeletal retrusive, I would no longer do this type of treatment. But I still do this type of treatment if I have what we discussed earlier with your moderator, the concept of lip incompetence, good airway, but 2A, right? So a 2A, I treat differently to a 2B. I minimize elastic wear in my patients because I find that unless I need the retractive force, there's a lot of side effects of elastics. And a lot of class 2s I see finish incorrectly skeletally because overjet is reduced by detorquing the upper incisors and dumping of the lower incisors. The easiest thing to do in orthodontics, as you know, is to resolve lower crowding by a procronation of the teeth. And this leaves, like you see in this case, if you look closely, you can see the dehiscence of the lower incisors because they've been pushed forward. So in my practice, after I've done functional jaw orthopedics, a lot of my class 2 correction is done with bite jumpers. And I'd recommend for those who may not have used it, what's called CS4. If you Google CS4, it's made by an American company called Dynaflex. And this is a very simple to use. It's like an upmarket version of your traditional Jasper jumper. But I prefer to use that because if I've set up my upper arch to the right dimension and I've torqued the incisors correctly, I don't then want to use those teeth for anchorage to bring the mandible forward because Newton's third law of motion I'm going to lose torque on my upper anteriors. I'm going to worsen the nasolabial angle, all for the sake of an overjet. Whereas if I use a fixed bite jumper, I'm able to get that done very easily. And I just put negative torque on my wires in the lower incisor region to help me to keep those lower incisors upright as I continue my class 2 correction. So in my practice, you'll see a lot of fixed functionals, followed then by straight wire, where I use a high torque prescription in the upper and a super low torque prescription in the lower. And then if that's not enough, I'm adding on my rectangular stainless steel negative torque and bite jumper type mechanics, right? So if you want to talk about push-pull springs or pull elastics, you know, it's all about trying to control the torque of your incisors and doing that after you've corrected the skeletal imbalance. So this is a MARA appliance. We'll talk more about this today. A MARA appliance, and MARA stands for Mandibular Advancement, and so M-A-R-A, Mandibular Advancement Repositioning Appliance. So with this appliance, it's almost like a fixed twin block. And I find that in a patient that has reduced lower face height, has a class 2B, it's very easy for me to reposition their mandible and then do mechanics to lock in their occlusion. And what I notice is that this helps a lot in patients who've had pre-existing problems as far as what you're seeing there. And these are problems associated with the temporomandibular joint complex, including not just the TMJ, but also the eustachian tube, also the muscles associated with forward posture of the head based on airway problems. And this is a very good paper in Acta Odonta Scandinavia back in 1999, where they looked at, and if you know Annika Isberg, she's published a very, very good textbook, which is one of my major teaching resources when I do my modules on TMD. She is a dentomaxillofacial radiologist from Sweden. And what she looked at here is, you know, what happens if we can surgically induce disc displacement in a rabbit. And this is what we are trying to prevent when we do our class 2 correction. We do not want to have heavy forces in a distalizing vector on our joint fossa complex, right? So as I said, I've been in practice 34 years, and what in front of you on this slide is all the different things I've used, right? And in this day and age, even though there is class 2 correctors with Invisalign, Dr. Sandra Tsai has been very instrumental in developing these. I still prefer, before I start Invisalign, to try and correct my skeletal imbalance. And I do my tooth movement with Invisalign. So in a growing individual, I do my orthopedics and I hold them there till they have a permanent dentition. When the 7s are up, then if they need tooth movement correction, I do it with Invisalign. In a non-growing individual with a normal mandible, I can use a MARA and then complete with fixed functionals. In a non-growing individual 2C, I can use the motion appliance and then finish in Invisalign. So a lot of my finishes are done with Invisalign, but I still feel that it's very difficult to control everything we want to do if we try and do everything with Invisalign. And I've seen lots of cases with elastics to the liners, et cetera, where you're getting a lot of dental camouflage versus true skeletal correction. So depending if I want molar distalization, I'm going to use what I discussed with you, the fixed distalizers, distal jets, pendulums. If I want intermaxillary dental changes, I use bite jumpers. But if I want true skeletal change focused on mandibular repositioning, I tend to use the MARA appliance. So I trained in London and I did my M.Orth. I then did my Royal College exams in all the other 4 colleges. So I have the equivalent of an M.Orth in those four colleges. And back then, the way you were rated in your finishes was things like lower incisor inclination to APO line, lower intercanine width, did you change it or not? So it was very cephalometrically figure orientated, not too much balance on the face. So, you know, if we look at this case, and this is a very excellent case, but I want you to look at it with the eyes that I'm looking at now. And this was done in 1998, and it won the BSSO, which was back the precursor of the British Orthodontic Association. Now it's it was called the British Society for the Study of Orthodontics, right? So if we look at this girl, she has a dental class 2 division 2, that's the dental. Skeletally, she has a retrognathic mandible, and she has a transverse problem of the maxilla. You can see the crossbite on the left side. So in my classification, which is vastly different to what I was taught at Eastman analysis and the Angle classification limited your treatment. Now, how would Angle describe this? Well, Angle would describe this as an Angle class 2 div 2, okay? But Angle had no cephalometric data. He had purely study models. When you add cephalometrics to this and you look at the face, you'll see that this girl's nasolabial angle is already obtuse. So we don't want to cause that lip to go back. The second thing you'll see if you do your Sassoon or Jefferson analysis is that her maxilla is in a relatively good position to cranial base, but her main problem is the mandible. So I have no problems in developing her upper arch and fully torquing her incisors to create an overjet. And the way I fix that overjet because of her face will be to bring her mandible forward. Now, I may do that surgically if her mandibular length is too short and if I've missed the opportunity of growth. But if her mandibular length is normal, I can actually reposition it at any age, and I'll explain to you why, and I'll give you the research of Dr. Rabi, excellent paper by Dr. Shamanto and Dr. Rabi, where they looked at herpes correction in non-growing class 2s, right? To show you what happens in the joint fossa. So I'm not advocating we can grow mandibles in non-growing individuals. What I'm saying is if I have someone who's at the right cervical vertebral age to encourage changes of mandibular length, then I'll take advantage of that. But if I've missed that opportunity and the mandibular length is normal, I can still reposition the mandible, right? And this is, I think, maybe slightly controversial, but to me, I do it every day. I have the literature, you know, and this is what is important to me. Am I achieving a good, stable result? Am I achieving a good airway? And if the answer is yes and yes, and I've been doing this for the last 20 years, then, you know, I'm not going to go back to some of the traditional papers and publications that talk about surgery only for these patients. I still do surgery, but you'll see I do surgery when the mandible is too small and I've missed the ability of facial growth to modify it. So in this individual, this girl has been treated with an excellent outcome using distalization. So in other words, this girl has had headgear to push her molars from class 2 to class 1, create space for alignment of teeth and correction of the canine. Now, if you look at her face before and after, I think you can see, look at her profile now. Her nasolabial angle has opened, and her profile is probably not as balanced and attractive as it was when she started. But the thing is, if you look at her occlusion, it's a superb, excellent result. There's good torque of upper and lower incisors, giving you a next to ideal interincisal angle. The molar relationship is class 1. The canines are class 1. You know, so when you look at everything purely from dental study models, you would view this as a good outcome, right? And this is where I want to talk about the controversy of extraction, non-extraction. This girl has had non-extraction therapy. She's had the equivalent of nowadays distal driving mechanics, okay? But even non-extraction can influence facial balance and can influence airway. So I want people to understand retractive orthodontics versus protractive orthodontics. Compromised faces, compromised airway, it's the term protractive orthodontics. So what could have this girl had as treatment if we wanted to have our cake and eat it? In other words, we wanted to have a good facial profile as well as a good occlusion. Possibly we would consider development of the upper arch to eliminate the crossbite. We would consider then repositioning the mandible to correct the overjet rather than retracting the 6 anteriors back to the current position of the mandible. And remember, when I was at the Eastman, we were heavily influenced by the work of Dr. Dick Mills. And Dick Mills would always say, you cannot change mandibular position. If you do, it will be unstable, right? So a lot of our class 2 planning was around the mandible, assuming that the mandible could not be changed in position. Now that thought process is absolutely changed in the literature, in the way I practice. So I want to explore those possibilities with you. But to me, this girl ideally required arch development, mandibular repositioning, then vertical extrusion of her molars to increase her face height and stabilize her mandibular positional changes, right? This is what we need to understand. And this comes from Sava. The nose and chin tend to grow faster than the dentofacial area in the early to late teenage years. So if you look at her before treatment at 12 and after treatment at 14, you've got to realize that her nose and chin are still going to grow, whereas her midface is going to stay where it is. So year by year, her face is going to look less attractive, okay? You've also got to then consider, did anyone check what her airway was like? She's an obvious mouth breather in that photo. And if there had been some baseline data of respiratory effort from the nose or apneic events, we would be able to maybe change our decision. And the future, as I said, I want you all to please read the AAO white paper on OSA and the role of the orthodontist. It's basically in greater detail with more references telling you what I'm trying to tell you here. So, my patients like a wider smile. We know that from the paper of Dr. Casco. My patients want fuller lips. We know that from the Peck and Peck research, right? So what we're trying to do is to achieve good facial aesthetics, but do that while we can still do it non-surgically. And for my essential textbook in my students when it comes to understanding timing of dentofacial orthopedics is this book. It's called Essentials of Facial Growth, and chapter 5 is very good, discussing maxillary. It talks about growth of the nasomaxillary complex and how the sutures undergo what's called intramembranous ossification. Chapter 7 talks about mandibular growth and what's called endochondral ossification. And if you achieve good tongue posture, good airway, and prepare the maxilla for the growth of the mandible, nature takes over, and a lot of my spontaneous class 2 correction occurs after I fixed airway and developed the maxilla. And you'll see that in the work of Frankie and Barchetti in one of the papers that I'll show you. So from that, I'm saying the maxilla is the template which tends to control the growth of the mandible. Excuse me 1 second, I'm just going to get one glass of water. Sorry about that. Okay, this is losing my voice a little bit there. Yeah, so as I said, Unifascial orthopedics, functional jaw orthopedics, the key to proper orthodontic treatment is the diagnosis. And if you look at the research of McNamara and Moyers on class 2, they show that 80% of class 2 actually have retromatic mandibles. So if we know that, I don't think we can continue to apply retractive forces on all our class 2s. For class 2As, absolutely, I think that's the treatment of choice. But how do you know? So two things my students have to present to me: a proper Jefferson classification, so I know if I have a 2A, B, or C, and whether it's short face, long face, or neutral face. And the second thing they have to show me is the mandibular length. And many cephalometric analyses don't include this. Mandibular length is normally from condylean to gnathian, and this is how we measure whether we've had any growth of the jaw versus just repositioning of the lower jaw. Sometimes it's very hard to trace condylean based on the superposition of your lateral ceph. So we can use another analysis or another point, which is called articulare. And articulare is used in the measurement of the mandibular length, and whether you use articulare versus condyleon, it's all very relative because of the software that is comparing it to the cranial base. So I look at maxillary length and position relative to anterior cranial base, and I look at mandibular length and position relative to anterior cranial base. Whereas if you do widths only, widths is going to show you maxilla to mandible, but that can give you, you can be widths 1 there in the face or back there in the face, right? But if you then want to look at maxilla in the right position, then mandible relative to that, you need to use a different type of cephalometric. So I can use articulare to Pagonian, or I can use condylean to gnathian. I just need to make sure my cephalometrics is set to measure both of those. And when I do that, that gives me the opportunity to look at the true changes of what I'm trying to achieve. Now, I quoted this paper earlier. Please read it because it might change the way you think about class 2. And I always thank my good friend Ian Edwards, who's now retired, to alert me to this whole concept. So this is a paper by Yu, Fishman, Rosenblum, and Suttonley, and is published in the American Journal of Orthodontics in 2001. And the purpose of their study was to look at the dental-alveolar changes related to mandibular forward growth in people who had class 2 malocclusions, right? And they talked about disarticulating the occlusion to minimize the effects of the adaptive mechanism and take advantage of forward mandibular growth. And they also showed in this paper that there was no statistically significant difference in class 1 and class 2 samples. So, you know, I think what you've got to understand from this research is that in many of our class 2s, we have a trapped class 1 mandible, right? Now, I'm going to quote a lot of McNamara papers, and if you want to get the full version of the paper, if you go to University of Michigan graduate programs, /ortho faculty, /McNamara publications, they're all there, and they're very, very good papers. So in this paper, back in 2010, this is with Frankie and Barchetti. We'll come to Frankie and Barchetti again when we talk about timing of treatment, and because their excellent analysis was able to demonstrate those changes, right? So they talk about spontaneous improvement of class 2 after expansion of the upper arch, and what McNamara then called the shoe and foot theory. So he said if your foot is your mandible and you can't get it into your shoe because the shoe's too small, you know, the option may be to enlarge the shoe, and that is your maxilla. In a follow-up paper, and in his textbook, he described again this concept. But people might think, well, this is a relatively new concept. But if you look at the teachings of Norman Kinsley, who was really one of the first orthodontists to start discussing the airway in class 2 patients, and he was in the same group of functional jaw orthopedics, such as Pierre Robin, such as the Rolf Frankels of the world, etc. So he talked about, this is in 1880, and obviously you then had the fathers of functional orthopedics, which included Frankel, Bimbler, Bolters, but all this stuff came from a lot of this pre-reading. So he said in 1880, the remedy in the lower jaw problem lay in widening of the upper jaw, so that the lower jaw could be put forward in its natural place, right? And he talked again about what Fishberg Suttonley had been talking about, which is disarticulation, so that the teeth can't be in the same accustomed position they've been used to, right? And then he proposed a new argument to advance the mandible, and he called this jumping the bite, right? So in his rules, during the treatment of class 2, the maxillary arch should be maintained in a widened orientation relative to the mandibular dental arch to assist in class 2 correction. And you want to do this during circumpubital growth spurts, right? And again, in Frankie and Bacchetti, that is CVM4. And so if I have arch develop early, appliance in during mandibular growth, I can correct most of these problems. So those who are not used to the Frankie Bacchetti analysis, it's very important to look at their excellent research. So the prepubertal growth spurt, which here is in green, is when I'm doing my maxillary changes, okay? When I have the endochondral ossification, which is the growth period, that's what we call the pubertal peak. And that's normally between the 3rd and 4th changes of the vertebrae. But where I will get the ideal treatment for my class 2 is going to be between CS4 and 5, right? And that's where you want to do the timing. Now, even after CVS 6, if your mandibular length is normal, that does not mean you need to retract all your upper anterior teeth back to that, right? So what we would be looking at in these individuals is the concept of timing for class 2 correction. And I want you to read the research of Petrovic, Bacchetti, McNamara, Rabi. All of these great researchers have all come up with the same message. So what I'm talking about tonight is low angle class 2, all right? And a lot of translation. I don't translate mandibles in a high angle class 2. So this is a sort of individual, the short face, what Bjork would call the forward growth rotator, or the hypodivergent growth pattern, where you have a short face height, you have a prominent labiomental furrow, et cetera, et cetera. As opposed to this chap, who's also class 2. So if you only use A and B or widths, they would show up as being the same type of class 2 pattern, but vastly different mechanics. The high angle class 2, this individual, he would need not translation, but molar intrusion and auto-rotation. So I'm not discussing those mechanics in this short lecture. I'm more discussing the 2B short. And if we divide 2B short into a growing or non-growing individual, that gives me the treatment. So I'll try and just open up, if I can here, the whiteboard. So my classification is one of 54 malocclusions. And Angle only had 4, okay? Because we've now included what Angle didn't have. He didn't have cephalometrics, right? So if we have 54 malocclusions and I then say I have a 2B, I need to know, is that 2B going to be a long or a short face, right? Now, if it's a short face and there is growth remaining, I want to time my treatment with a functional appliance to bring the mandible forward. If it's a long face, I'm going to do intrusion mechanics, right? Now, on the short face, when can I do functional jaw orthopedics? Well, ideally, remember, during CVM 4 to 5. That's important, right? But if I have a normal mandibular length, as you were saying, then I can do it at any age. But this is part of the criteria I need to look at. Because if you add now to this classification, the mandibular length, which is condylean to Gnathian, it then tells me whether I have a small mandible that I need to increase mandibular length or a normal mandible that I need to reposition the mandible, right? So let me show you that. So if I have a small mandible, I use a technique known as IMDO. So IMDO is like a green streak fracture here, not a full BSSO. And then we put in a custom-made distractor. The patient turns there using the classical 1 millimeter a week distraction technique. And then what I do is I'm increasing mandibular length, right? I'm increasing mandibular length because I'm genuinely distracting the mandible. So that's how we correct a short mandible. In a normal mandible, it's all about joint fossa relationship. So that is, right. So that is my mandible, and my mandibular length is normal, but I have a class 2 situation, right? I can reposition this mandible here, and that gives me my correction of the class 2. And what happens, and this is what I'm going to show you in the research of Barchetti, Franchi, in the research of the originators of the appliances that I'm going to discuss, which is the fixed functional appliances. You'll see that what happens if I was to focus on this area well after the treatment, it would appear as though my joint fossa has gone back to where it started, but really it hasn't, because my mandible is still class 1, right? So what has happened? What's happened is the retrodiscal tissue has remodeled. And Rabi, who I think is Egyptian by background, maybe I'm saying that incorrectly, Rabia maybe is the correct way of pronouncing, but Bakir, if you look at his excellent research when he was in Hong Kong, right? He studied all of these changes, and he talked about the cascade that allowed joint fossa remodeling to occur, even in non-growing individuals. And if you understand the biology, as Dr. Rabi definitely did, you'll see that this stuff is still possible to do. Okay, now I want to make sure that my screen is going to go back to normal. So I'm hoping that's now back on the slides. Yeah, so when I have a 2B short, I have 3 options: growth modification, camouflage, or surgical correction. When I go surgical correction is if my mandibular length is small and it's a non-growing individual. I don't do the camouflage anymore, right? But I do try and do the growth modification based on the work of Franchi and Barchetti during the cervical vertebrae changes 4 and 5. So here's a classic example. This young girl comes to my practice. She has a similar malocclusion to the girl who was treated and won the BSSO MOF award. But if you look at this girl, you can look at her profile and you can see that she is biskeletal retrusive. So she's 2B when you look at maxilla and mandible, but her entire maxilla and mandible are retronative relative to her cranial base, right? So she is the individual that when I trained at the Eastman, I would consider headgear and possibly then extraction of upper fours. But if I now apply my orthopedic hat and my airway hat, I realize this girl needs torque of her incisors, creating an overjet so that I can unlock the mandible and bring it forward. And sometimes I achieve that torque with partial brackets. Whether I need arch development or not would be a separate issue that would be measured by my Shorts analysis. So in my classification, I need to know Shorts Corkhouse figures so I can determine if I need the mandible develop before the maxilla develop before the mandible comes forward. Finally, and this might sound crazy to a lot of people, but sometimes while I loosen the maxilla with my expansion, I protract it with a face mask, even though it's class 2. Most people think face masks are only for class 3 individuals. But if you have a biskeletal retrusive individual who's 2B, you need to develop the maxilla and bring it forward into its correct size and spatial relationship to cranial base before you think of bringing the mandible forward. So for this girl, she had some expansion. She had then a twin block, because back then I was using removable correctors. And she ends up, before any fixed braces, with a much better occlusion, which I now can finish in the modern era in Invisalign. Why not? Because I have stable joint fossa remodeling. She's got this is the type of treatment that I want to advocate. Whereas if I try and correct her purely with orthodontics, I'm going to have to camouflage the true class 2. And that would mean I'd take out upper fours, I'd use a lot of class 2 elastics. And, the difference is very much in the face, in the airway, not just in whether we get Andrew's 6 keys of occlusion, right? So this girl has had some orthopedic development, some mandibular translation, done at the appropriate age so that we minimize the need for retractive orthodontics. Why? Because she was a 2B short, not because she was a 2A. A 2A long is a perfect case for the retractive type procedures. So many people talk about an as-if position. What is an as-if position? As-if position is if I see that someone's face improves by asking the posture of their jaw forward, then more than likely I know I have a low ankle individual. The second thing is if I look from the front while they bring the mandible forward edge to edge, and I look at the width of the maxilla to the mandible, I realize that I may need arch development prior to mandibular translation, right? So if we look at all the papers dealing with functional appliances, whether they're a twin block, a bionator, a Mara, right? They accelerate mandibular growth. They still have some restraining effect on maxillary growth, and that's why I designed my Mara slightly differently. And you are going to get some dentoalveolar changes. Knowing what dentoalveolar changes you get, you've got to put in more torque in the upper anterior teeth, less torque in the lower anterior teeth, okay? So which appliance now, right? So let's assume you understand where I'm coming from, that if I have a 2B short at CVM4, then I'm ready to go to bring my mandible forward, assuming my maxilla has been developed at an earlier stage. Well, how can I do that? What age should I do that? And is there one appliance that's better than the other? Now, we talked a bit earlier about looking at the evidence. And, I've read many, many papers in my 34 years. And I want you to understand that the best available evidence, you need to read beyond just the conclusions of the paper. Look more closely at the methods and materials before you want to apply that evidence clinically, right? So, did the paper measure mandibular length or purely just A and B differences? If it only measured A and B differences, like those 4 papers I'm showing you there, maybe they're not seeing the changes that I'm talking about. So we need to make sure that any paper we read looks at mandibular skeletal growth. And I would recommend the Frankie, Barchetti, McNamara, Kurt Fulton was a fourth author from Brazil, when he looked at these exact changes. Murray Meikle, who was one of my instructors when I studied at the Eastman in London, you know, he talked about those 4 papers on class 2 correction. And he said, look, they were expensive. They confirmed already what we knew. They focused on the average effect. And they, most importantly, didn't measure the changes in growth rotation or condylar fossa. Now, that's what Buck-Rabi looked at. So, you know, you talk about evidence, you've got to talk about apples and apples, right? So I think Buck-Rabi had brought forward this whole concept of skeletal enhancement based on age and maturity markers. And that means that I now do my class 2 correction, my MARAs, much later than I used to. I normally do it between the ages of 11 and 12, when we have the first premolars already erupted and when we see the CVM 4 to 5 changes, meaning the 4th vertebrae is curved, but the 5th one is still flat. Right? Now, which appliance do I use? Well, I think the focus of any lecture shouldn't be based on appliances. In my hands, in my practice, which is a high volume, busy organization, we don't have time to deal with people who are not complying. So I no longer use the removable appliances. What I use is fixed functionals. And by the time I've done that, I'm straight into my fixed because of the age I'm now treating. My 7s have fully erupted on most of these individuals. So I combine MARA or advanced sync with prescription known as a class 2 prescription. And, you know, when I ask an orthodontist, what prescription do you use? Many of them say, I use Andrews, or I use MBT, or I use Roth. That clearly shows that they don't have an understanding of what that prescription means. The correct answer in a good orthodontist, if you want my opinion, I use whatever prescription the patient's malocclusion requires. So if I have a class 2 individual, my prescription would be a high torque upper, low torque lower. And if I'm going to be using a lot of bike jumpers, I'll put negative torque in my lower wire, et cetera, right? I know that whatever appliance I use, I'm going to be advancing my mandible, and my curve of speed then will be obvious. So my lateral open bite will exist. And if you look at the work of Peter Ngan, Ngan, with Dr. Terry Dissinger, they talk about bracketing in the lower arch your premolars a lot more gingival, so that we're leveling that curve of speed during our case finishing. So whichever appliance you use, does it fulfill these 6 criteria, right? So to me, the appliance that does is called a MARA. It's easy to fit, easy to adjust. Why do I want to adjust it? Because if I have a 15mm overjet, I don't want to advance that jaw forward with one bite jump edge to edge. I want to bring it downward and forward with incremental advancements, what we call stepwise titration. Because every time I bring it down and forward, I'm having more of a joint fossa remodeling effect on the condyle, right? So it needs to be titratable. It needs to be integrated with fixed. When I use twin blocks, I had a problem when I stopped using the twin block. I had to make some sort of appliance to maintain mandibular position and then start fixed braces. Whereas with something like a MARA, I can combine the fixed braces while my mandible is being held. So what I like to say is I'm doing class 2 correction in class 1 time. So let's look at the MARA. And as I said, this is not a lecture about MARA, but it's just a lecture into how I've changed my philosophy in class 2 diagnosis and how I use an appliance, which is easy to comply with those movements. So with the MARA, anchorage, I need to figure out whether I have a 2C or a 2B. If it's a 2B, I don't want the headgear effect, right? So that means in my upper, I'll have a TPA. This diagram shows stainless steel crowns on your 6s, a lingual arch, and on the lower 6s, you have a what's called a an elbow and then an arm, right? Now, what happens is the elbow is in the upper and it hits the arm and advances the jaw forward. When I want to advance it more, I take out this elbow and I add another shim. So that can give me a 2 millimeter stepwise advancement, okay? And as I said, I use this in adults, assuming mandibular length is normal. This is a adult patient who didn't want braces, was very class 2. So you can see I'm correcting the class 2 while I'm starting orthodontic alignment of the teeth using aligners versus fixed braces, right? So that is a possibility. Now, James Eckhart, who's a good friend of mine, he is a very successful orthodontist and very well published in the MARA, and he is a 1 hour drive from LAX airport. If you're ever going to the US, whenever the borders reopen, and you want to spend some time with a good clinician to learn in practice how we fix it, he's the guy. But the guy who did most of the research is from Germany. His name is Dr. Douglas Toll. Unfortunately, he passed away a few years ago. But can you see behind him in this diagram, you can see his research, what I was showing, which is when the condyle is brought down and forward with a normal mandibular length, the joint fossa remodels, so it's keeping that class 2 correction in the right position. And that's how we know that these appliances can be effective, right? So effectively, you're looking at a fixed twin block. When the patient bites, they have to bite ahead of that arm. In the lower, you can see you've got the arm and you've got a pad so you don't have the irritation on the cheek. In the upper, you've got the elbow that allows the stepwise advancement. And when you put the arm and the elbow together, you've actually got the ability of repositioning the mandible and then dealing with the fixed braces at the same time. So if any of you want any of the papers that I've quoted in my lecture or a copy of these slides, please send me an email. Now the best email to use, I'll just put it up here. So it's just info at Mahony, no e.com. So info at derekmahony.com. The subject heading should just be something like Egypt lecture class 2. And if you do that, I'll get my staff to send you the papers that we're reviewing, including this excellent paper, which is a good clinical summary of how to use the MARA. This is by James Eckhart. I've already referenced him. And what's good about this paper, it shows adults and children. Now, that's how it works. You can see as long as you have correct torque of the upper to the lower, as the patient bites, the mandible is advanced forward. And as the mandible advances forward, you end up having that twin block effect, right? You can combine, if your maxilla is narrow, a development appliance. So in that way, rather than make a separate expander before my MARA, I can do my arch development, and when the arch width of the maxilla is ready for the mandible, I could then put in my upper elbows and my lower appliance, right? But the concept is once you've developed orthopedically and brought the jaw forward, then you go to fixed appliance therapy using a high torque upper prescription, low torque lower. So this is the classical patient. You can see he is class 2 low angle. He's a 2B. His treatment involved stepwise advancement with a MARA and then fixed. And you can see he ends up with a much better lower anterior face height. You can see his class 2 correction, his nice arch forms, okay? And if you superimpose, you'll see minimal tipping of the lower incisors, because in many class 2 cases I see, including when I examine my patients for their final 10 cases, if I see a class 2 where most of the class 2 correction has been by lower incisor proclination, I need to question why that was not controlled, right? And you can see here, most of the change is in the mandibular position as opposed to dental-alveolar compensation. Another girl, a little bit narrower arch form, full unit class 2, CVM 5. And for many people, they would say, well, she's way too old for any class 2 correction other than surgery. But again, read the paper by Suttonley Fish Yu. You'll see that provided mandibular length is normal, you could still achieve good correction of her class 2 with stable outcome. And we'll talk about retainers towards the end of the lecture, but the retainer I like to use is called a bionator. And many people think a bionator is just for children to use at night. It's not. A bionator for this girl to be worn at nights after her class 2 correction would help the joint fossa remodel, help the muscles of mastication to adapt to the new mandibular position, right? So you can see here those changes in the lower anterior foci, right? Now, here's some controversy. This girl has a history of TMD. She's Div 2. Her function has been distalizing forces, and just simple correction of the Div 2 automatically improves her joint problems, but then stability is going to be bringing that condyle downward and forward. And again, because her mandibular length is normal, it doesn't matter that she's an adult. The concept is to overcorrect with your Mara to an edge-to-edge position, and then settle the lateral open bite using the Nairn-Dissinger bracket position. And see the end result? Good profile, free of TMD type problems now, good interincisal angle, adequate torque of both the upper and lower incisors. You know, these are the sort of cases that we want to look at. But in an adult, you're going to obviously get a little bit more dental alveolar change than skeletal change. And that's why in an adult, it's very important to make sure that you don't finish like this. If you look at the lower incisor, this should be at 92 degrees to mandibular plane. It's about 120, right? So that means that there's been a lot of dental alveolar compensation. How do you limit that? Various tips. I like using an ART auxiliary, ART, and I put that in the lower arch wire. That helps upright as I continue to move forward. See, many people only use the overjet as a guide, and they think when I'm edge to edge, I'm done. But if you're edge to edge and your lower incisors are like that, you really still have an overjet, because if you torque the upper incisors to the right 92 degrees, you'll see you can still advance more off the mandible, right? So that's the shim that I use to bring the lower jaw downward and forward. The Mara comes as a kit. It's got the elbow for the upper stainless steel crown. It's got a lingual arch for the lower stainless steel crown. And then you advance as required. You can see what that does. It brings the jaw forward. Now, here's an important diagram. Look at the upper elbow. Can you see it's torqued correctly so it hits the middle of the lower arm? If you have the upper elbow not adequately torqued, there's a chance a patient could slip to the right or left or lock, so it could worsen the TMD problems. How long do we hold the patient? Simple test. You don't necessarily have to do joint fossa x-rays, but on average, the treatment is 12 to 14 months duration. And then in the new position of the mandible, I make sure that my buccal segment has closed, the lateral open bite is closed. We then palpate the anterior berry of temporalis. And I want everyone to do this. If you bite now in a class 2 position and you bite hard, you'll feel this. If you bring your jaw forward edge to edge like that and then bite, you don't feel this, right? So that means that you have a Sunday bite. One of the things that Frankel had talked about is that one of the muscles that will remodel to show you stability of your mandibular position is going to be temporalis. So if anterior berry of temporalis fires when the mandible is in the forward position, that's a good sign of stability. I still will retain with something like a Damon splint or a bionator after my orthodontics, because I know that the teeth can be moved very easily to close the lateral open bite. The joint fossa is going to take at least 6 months to remodel, but the muscles could take at least a year to remodel after the joint fossa. So that's why in the war between teeth, bone, and muscle, we know that muscle always wins. And this is the excellent research, as I said, of Rabi, and also we looked at that diagram where we were able to show Douglas Toll's research, and I'll send you both of their papers if you email me. You can see what happens here is as the condyle comes down and forward, that whole joint fossa remodels to give you stability. But the muscle then also needs to readapt. This is a paper by Von Duras and Kuftenack that explains exactly what we're talking about. When you have the mandible coming downward and forward into an orthopedic mandibular displacement, you don't grow the mandible. So get out of the idea of thinking that ramal height will increase. Not really. Most of the changes are joint fossa in a non-growing individual. And what happens is you stretch the retrodiscal tissues, you get perfusion of synovial fluid. The synovial fluid brings the cells you need that allow you to get the bone remodeling to occur, right? So the Von Duras and Kuftenack published this paper in the American Journal of Orthodontics, and they called it the growth relativity hypothesis for condylar and glenoid fossa growth, right? And they talk about doing multiple displacements so that you get, more than one bite off the cherry. And they showed that in a three-dimensional picture. But then if you look at Rabi's research, you can see how using photomicrographs of undecalcified parasagittal sections of animals that have had fixed functional appliances, that tetracycline vital stain shows you that new bone I was trying to draw, right? So it's a very well documented protocol. And you need to read the papers of Rabi, of Frankie Bacchetti McNamara, and of Dr. Toll, so that you can see how in a non-growing individual you can get stability provided mandibular length is normal and provided you allow time for the muscles to remodel. And sometimes you are going to get relapse. That's why I don't just remove my Mara and my braces at the same time. I wean the patient off the Mara so that I can check that I have a stable position of the mandible. And then I allow the muscles to still continue to remodel in the retention period using things like a bionator or a Damon split, right? Because the major cause of relapse is going to be the natural pull of the muscle to be retrognathic. And there's other tips that I can share with you in future lectures, such as incisal build-ups and making ramps on your upper sevens. But please remember, the skill is develop the upper arch correctly, advance appropriately, close lateral open bite, right? Then allow joint fossa remodeling. Finally, check muscle migration, because if you do all of that, you'll get good stability. But do it in class 2 brachyfacial individuals. Don't do it in a long face individual. If you want to invite me back later to do a lecture on high angle class 2, you'll see I don't use any Maras in a high angle class 2. A Mara works well for this low angle individual because it will increase lower face height by allowing molar eruption, okay? The later you do it, like CVM 4 and 5, the more chin projection you get. That's what McNamara and Bacchetti had shown in their papers. If you do it in a high angle individual, you'll end up with the face looking worse, because when you've translated and extruded the molar, every millimeter of molar extrusion is causing backward rotation of the mandible, which you don't want in a high angle case. Whereas in the low angle brachyfacial individual, that's exactly the type of changes we want to see, and we want to maintain that lower incisor position. Very important to control torque of the lower incisor as you're using your Mara appliance, so you end up with more skeletal change and less dentoalveolar compensation. So how do you prepare the upper arch? If the molars are rotated and it's narrow, I like using this. It's called an NPE2. It derotates the molar, gives me arch development. It's very rare that I have to do things in the mandible, but I can't expand the mandible. However, I can upright the lower teeth if I need to, right? So we do arch preparation and we do torque, then we place our Mara, and then we finish in braces, okay? I can use it unilaterally by not putting a elbow on one side. So those cases where the mandible's back on one side, not the other. But it's very important I get the right torque of the incisor, because my upper incisors are under torqued. It's going to prevent full translation of the mandible. So they're the results I want, and we hold it there in either a Damon splint or in a bionator at night. I can use these in bruxes, and the benefit of this compared to other appliances, well, first of all, facial changes are amazing, and I've done maybe 4,500 MARA cases. So I have good experience in this. Unlike the Herbst, which does the same job, but I can't get my fixed braces on the Herbst because the piston gets in the way, right? Obviously, I'm not using it in a case that needs retrusion because the MARA is giving me the protrusion. If I want to limit the headgear effect, I'm putting in a TPA in that situation. And they're very easy to fit and adjust. Unlike the twin block, speech is not affected, which is a major benefit for my patients. And most importantly, I can combine them with fixed appliance therapy. I use it in TMJ patients, provided that we've got a stable disc fossa position. Now, you can't use bands for the MARA. The forces are too heavy. I've tried everything, including welding two bands together. You need to have a stainless steel crown, right? Now, what I do is when my lab appliance comes back, I can eggshell the stainless steel crown. So I have then the ability to cement it like a band, all right? This is the point I was saying with the torque. One thing you need to do with the MARA is you need to be able to torque the incisors correctly before you advance. The second thing you need to do is you need to make sure that when that mandible is advanced forward, that the upper elbow is torqued correctly to the lower arm, because if it's not, you're going to slip out like you see in this diagram, right? So one of the things you need is a torquing tool for the upper elbow, and it comes in the MARA kit. So you can see here, if your upper jaw wasn't developed first, your upper elbows are going to tip like that. Very difficult then to get proper contact with the arm. So please develop your upper arch first to avoid that sort of dogleg appearance. You can see here, I like to combine my MARA with an expander if I need to, and then only add the lower component when the width of the upper is good. I band my sixes, and then when I'm advancing, I need to always check from the front of the mouth that the torque of the elbow matches the arm of the lower. This is my torquing gear, and we take the elbow outside the mouth. We hold it with the torquing gear and any sort of plier. Here you can see I'm using a jarraback, and as I hold the jarraback, I can change the torque of the elbow. And all of these are described in my YouTube video. So I have a YouTube video on how to fit a MARA, how to remove a MARA, how to torque the elbow, how to stepwise advance. There's about 8 videos I put on MARA, each of 1 hour. I'm just covering very quickly for you in this lecture. But if you want more, email me and I'll send you all the YouTube links to the MARA videos. So can you see here? Good torque is important, because if those vertical legs of the elbow are not torqued tight enough, you can get that lower jaw dropping backward, like you see here. Here, the elbow is too wide. When I torque it correctly, the patient slides forward. And that's what we want for the class 2 correction. Right? So all of these papers, there's about 20 of them, I'm happy to send to you. I can also send you a manual called the MARA manual, but I think nothing's better than looking at the videos on YouTube for the clinical side. The theory side, sure, read the Rabi papers and all that, but you know, I'm a clinician and a researcher, so I like to put the good documented research into clinical practice, and we overcorrect our MARA cases based on that research to edge, right? So all of these adjustments, because we're just kind of running out of time for this lecture, and I've got to be somewhere very soon. So So, you know, if your patient doesn't slide forward, but kids tend to do this, they tend to play on that upper elbow, then you can cause breakage of the crown. That's the only time I see breakages. So it's very important when you fit these appliances, you tell the patient not to bite in their old position, but to gently teach them to bring their lower jaw forward. And one way of preventing that, is this sweep back. If your leg is too short, it's going to be easier for the patient to drop back. So one adjustment is the torque of the upper elbow, and the other is the sweep back bend behind that elbow. Remember, I don't just put a MARA in. I've already developed my upper arch. If it was a Div 2, I would have put 4 brackets and corrected the Div 2. So I use 3 things: upper arch development, upright lower molars with torque, try and get a good interincisal angle so I can then bring the jaw forward. In the upper, I tend to use a TPA for 2 reasons. One, it prevents the headgear effect. Number 2, you can only fit the crowns the way the lab made if you put them on at the same time. Whereas if you can see in this diagram, if I fit my upper stainless steel crown with a bit of rotation incorrectly, then I'll never be able to get my elbow in. You understand? Whereas if I fit it the way the lab made the elbow, I know it's going to fit. So that's another reason I like to use a TPA. It's easier to fit the crown's exact rotation. You prevent the headgear effect, so you're getting more lower jaw movement. Sometimes if you're getting excessive dumping of the lowers, I put a lot of negative torque in there, right? And if worst case scenario, I don't have enough torque from putting the torque in the wire, I can use an auxiliary called an ART auxiliary. If I'm getting too much headgear effect, in other words, my molars are being pushed back into a position as opposed to the mandible coming forward, then I could get better security by putting torque so that my upper roots of my molars hit the cortical plate, right? In severe cases, high anchorage cases, I'm getting this sort of thing. You see, I'm bringing the mandible forward, but I'm also getting a lot of headgear because I'm getting a lot of space between my 6 and 5 and my 5 and 4. So in those cases, I can add a TAD to the TPA. And if I add a TAD to the TPA, that will give me solid upper anchorage so that I'm getting no headgear effect, right? So torque is important of that elbow to push the roots in the cortical plate, or torque with the TPA, with a TAD. You know, these are all the tips to try and get the most skeletal change and minimize the dentoalveolar change. Normally I see these patients 8 weekly. I give them a booklet that explains to them what to expect in the first few days and what not to do. Children in particular tend to play on those arms, and I want them to stay slightly in front of those. I don't get x-rays like I used to check joint fossil remodeling. I just look at the muscle thing, but normally 12 to 14 months. You know, every visit, the bite deepens, so then we do have to re-advance. That's what the stepwise advancement is. You can see here, deep bite, I stepwise advance, and I open that bite. You know, we over-treat. We treat edge to edge because we know from Frankel's research, it takes a lot of time for that muscle to remodel, and I'll get some of that muscle wanting to pull back, right? In the mouth breathers, I get them to wear an elastic between the elbow and the arm. That just stops them from dropping the mandible back. Or you can use longer vertical legs on your elbow. Ormco, who make the MARA through their lab called AOA, are very helpful at helping you select the right design. To remove, remember that the lingual crust of the upper molar and the buccal crust of the lower molar tend to slant. So that's how you should pull those crowns off. They're easy to get off if you remove via the slanted surface rather than the vertical surface, right? There's videos of me showing you how to do that, but a little tip is try not to have to high speed the crown off, because if you do, there's risk that you might be cutting the enamel underneath there. I tend to put this little groove on my stainless steel crown before I cement it, and I section the crown so that the cement has ability to extrude, and then I use that little groove with a very sharp band removing plier to easily peel, and I peel away, as I said, on the lingual of the upper, buccal of the lower. And if you do that, these are very simple to remove, and there's a video showing you step by step how to do that. Once I've removed them, I still maintain my class 2 vertical with a bite ramp while I start settling my posterior teeth. And remember, I don't want a flat bite ramp because the mandible could still drop back. I want that bite guide so that the incline is what we call a reverse incline bite plate. And Bill Clark, after he does his twin block, has an upper Hawley where he puts the acrylic in this angle. We can do it with a turbo so that we can get on with our fixed appliance therapy. You can see here the turbo bonded behind the incisors. When the patient bites, the molars can still be extruded. So these are the videos I was talking about. If you go to YouTube and you go to the AO Mara, so YouTube, the AO Mara, all those videos are there. Dr. Toll taught me a lot, as is Jim Eckhart, but the Mara manual is fantastic. So when you email me, ask for the Mara manual, you've got the link to the videos and or any papers you want. AOA laboratories are fantastic. They produce the Mara manual, and that doesn't mean you have to use them. Many labs make Mara under license. I do so many Maras, I have the crowns already chairside, and I then select what I need. But if your first Mara case, do your scan, send it to the lab. They will manufacture for you. Now it's all digital. Back in the day, we used study models like that. But I hope you will try the Mara, because I think it's a great non-compliance solution. This is my good friend, Dr. Frank Bogdan, excellent orthodontist in New Jersey. And, he's talking here about the Dissinger position, where once he advances his Mara cases, he can erupt the teeth. So this is a classic low angle 2B. She has a nice nasolabial angle. You don't need to do much retraction of the uppers. You use the Mara, then you go to a high torque upper, low torque lower. You slowly wean the patient off the Mara, erupting the posterior teeth. So you end up with that beautiful buccal segment and that nice profile, right? So lots of articles on the Mara that I'll share with you. Lately, just for more comfort for the patient, I'm using Terry Dissinger's Advanced Sync. And although that's a little bit more cumbersome for the adjustments, it's certainly a little bit more comfortable than the Mara. So if you're worried about cheek digging in, this is like a miniaturized herb. So it's an excellent appliance, right? So doctors, with that, I will end the lecture. I was a very brief overview on what I do for class 2. I hope it's been of use to you. Remember to email me if you want further information. But with that, I'm going to end this seminar. I said I'd speak till 7:30. We've gone a little bit over. Sorry about that. But if you have any questions, please email them me. But thank you very much again for the invitation to speak. And
it's our pleasure. It's our pleasure, Dr. Derek. Thank you very much for this fantastic lecture. And let me invite Professor Ashraf Atiyah, the Professor of Orthodontics and Dental Orthopedics, as well as the former Vice President of Al-Azhar University. He had technical issues before the start of this meeting. Thank you very much on behalf of our students, our residents, and all of the participants in this webinar for this fantastic lecture. Thank you very much. And the stage is for Dr. Ashraf to moderate the question section. Thank you, Dr. Ashraf. Good morning, Dr. Derek.
Hi, how are you?
Hi, how are you? Sorry for the inconvenience. I apologize for coming late because I have some technical errors, but I was able to listen from the beginning of your presentation. But so sorry because I can't catch you at the beginning of this lecture.
No problem.
Anyway, on behalf of Al-Azhar University, I welcome Dr. Derek Mahony from Australia, founder of Full Face Orthodontics and Dental Sleep Medicine Center.
And thank you, really, thank you too much for your amazing lecture. And I welcome you on our webinar. We highly appreciate your effort in this lecture. And the Mara appliance is very attractive for me to start to work on it. Anyway, we have a lot of questions. I try to select some of these questions because I know that you exert a lot of effort, and I see you drink a lot of water. So, I'm starting from with Dr. Davinder Singh. His question: when would you use myotherapy appliances like myobraces?
Yeah, so myobrace is used when you have abnormal swallowing pattern,
Yes.
Tongue thrusts. I use it as an adjunct to help tongue posture after I do lingual frenectomy, you know.
Yeah.
But I don't think a myobrace can really be used in a severe class 2 to correct the class 2. I've tried it in the past. Children find it impossible to keep in their mouth when they have such a big overjet. So there is a use for the myobrace, and my PhD research, when we did the orthopedic phase 1, developed the upper arch, brought the lower jaw forward, the kids were still in mixed dentition. So while they did myofunctional therapy, we used the myobrace as a retainer, almost like Frankel 2.
Yeah.
Yeah.
Oh, okay, thank you. Another question from Dr. Syed Muhammad. What are the criteria to consider that the mandibles of normal size?
So you have to measure like every cephalometric software package will give you a maxillary and mandibular length based on cranial base. So if your mandibular length is 2 standard deviations smaller than it should be for that cranial base, then you either need to do surgery because you have a non-growing individual, or that's the time to try and get as much class 2 correction as you can with functional appliances, right? But if your mandibular length is normal, then most of the times, as you see from Sutton Lee Fishberg's excellent research, your mandible's kind of trapped. It could be trapped because of Div2, deep bite. It could be trapped because of thumb sucking, you know. So I think we see a lot of people who have an overjet that have a normal mandible. And most of that then is dental-alveolar change. But if you have a true skeletal small mandible, you either have to operate with the distraction procedures, or you reposition and take advantage of growth. Okay?
Oh, thank you. From Ali, do you fear double bite development in mandibular repositioning in a non-growing adult?
I think all non-growing individuals have a higher tendency to what's called a Sunday bite.
Yes.
But if you wait and let joint fossa remodel and muscles readapt, it's actually a very stable outcome. However, I do ask my adult patients to wear their nighttime appliance for a lot longer than children. Children, I normally have 18 months nighttime wear. Adults, I'll try to ask them 18 months every night and then cut down to 1 or 2 nights a week, but never stop. Now, if they wear that every night, it actually does promote very stable outcomes.
Yes, yes, thank you. From Dr. Muhammad Tawfiq, what is the proper management in cases with decreased mandibular length due to decreased ramal length?
Yes, so if your ramus length is short, then I do distraction of the ramus. Because again, they tend to be more the high angle patients. If you have a short ramus, they tend not to be brachiofacial patients. And when if I lecture on a high angle class 2, high angle class 2s, we used to treat the mandible by impacting the maxilla. But you still end up with this very weak gonial angle. So if you look at the newer surgeries for high angle class 2, it involves very much posterior rotation type surgeries. But in growing individuals, I can do distraction of the ramus, much like I've done IMDO. So if I have a mandibular length problem that's related to obviously the body, then we cut between the molars and we distract that way. But if we have a problem more on the ramus, you can do ramal distraction. It's a very, very successful procedure. Yeah. But I don't see ramal problems in these types of individuals. The 2B shorts tend not to have short ramal heights.
Yes, yes, thank you. From Dr. Abdullah, can you clarify the green stick-like fracture you induce to enhance mandibular length increase? And is it for growing patients?
Yeah, so if you look at the work of Al-Azhar on long bones, his protocol is still used now in facial bones. And the green streak fracture is not a cut through the cortical plate, right? But as the term green streak induces, it causes injury so that the body starts repairing itself by forming callus. Normally after the green streak fracture, which you can do adults or children, you wait 7 days, called latency period, for the cells to arrive for repair. Then you start the slow distraction of those two fragments. So the fragments are not actually cut through and through as you would see in a BSSO.
Okay, thank you. From Dr. Muhammad Abu Bakr, like Dr. Bakr Rabia. He's Egyptian, as he said, he's Egyptian but live in Hong Kong. His question is, if in non-growing individual, if for some reasons I'm not able to use fixed functional appliances, what is your appliance of choice given that it is a non-compliant patient?
So if the question is right, we're talking about an adult who's non-compliant, right?
Yes, yes.
Yeah. So I like using a spring called CS4. You can Google that, CS4. It's a very comfortable bite jumper. I used to use Forces appliance from Unitech, but the Forces I found used to break a lot of lower brackets the way it's put. The CS4 is very, very easy. It's got a ball joint that slides onto the upper and lower Y, and then you connect it. You use it for class 3 and class 2. It's very, very nice. But of course, it does cause a lot of lower incisor procronation. So before you fit it, you need to have good anchorage control and a lot of negative torque in your wire, which is normally TMA or stainless steel.
Yes.
Dr. Ashraf, I Googled this device. It's actually on the screen, Dr. Derek. Can you see it?
Okay, so what screen? See,
my screen.
I don't know.
I have shared it. Okay, so I hope that you can stop your sharing your screen and you can see this screen. It's now I have Googled it.
I see it, Dr. Khalid, on my device.
Okay. Oh yeah, now I see. Yeah. Thank you. I got that.
Is this one? Is this one? Okay.
Yeah, that's it. That is it. Correct.
Okay. Thank you.
Yes, thank you, Khalid. Thank you. Another question from Dr. Ali.
Yeah.
No, another question from Dr. Muhammad Shindi. He's my friend. How could you correct curve of SPE during a mandibular advancement without extraction?
Sorry, I don't understand.
How could you correct curve of SPE during the mandibular advancement without extraction?
Yeah. So depending on how deep the curve of SPE is, obviously for every millimeter of depth of curve of SPE, you need space for flattening, right?
Yes.
So what I use is the technique of Chris Chang, where I put TADs in the superior oblique ridge of the mandible. By using those TADs and by using Terry Dissinger's bracket positioning, which tends to give me because in the old days I'd use reverse curve of SPE, but the reverse curve of SPE just dumps the incisors, and that's what I don't want in my finishes, right? But to prevent dumping of the incisor, we use a TAD in the superior oblique ridge of the mandible. Now that TAD with class 1 pull allows me to level curve of SPE and increase arch length without the unwanted side effect. That works very well. And Chris Chang has a very good video on talking on YouTube on using, he calls it bucket shelf TADs and curve speed. It explains it very nicely.
Yeah, thank you. From Dr. Ali, what's your opinion about carrier motion appliance for class 2?
Yeah, so Carrier is good for 2C. Now remember, when Louis Carrier developed the appliance, he called it Carrier distalizer, and that tells you what it's really used for, right? Then all of a sudden it's become motion appliance. I've done a lot of motion cases, and anchorage is important. In the class 2s, I used to use what Carrier talks about, which is a lower vacuum retainer. And then I put a bracket on the terminal molar. But I've had a few patients who didn't wear the retainer, but wore the elastics. Now, these are orthopedic elastics, 8 ounces. So I got root resorption on those cases on the molar. So now I use the motion to a lower TAD. And I put the TAD exactly where Chris Chang does, superior oblique ridge of the mandible. Now, with the lower TAD and the upper motion, you can distal drive that entire buccal segment, canine to second molar, back to class 1. But I only do that if I need distal driving, you see? If I need mandibular translation, then I prefer to use the Mara or the advancing.
Thank you. Another question from Dr. Sayed Muhammad. He said, you mentioned that you use bionator as a retainer for class 2 patients.
Yeah.
Do you use the same conventional design bionator?
I use the design by Balters, and if someone emails me, I can send you the chapter from his book. Balters, B-A-L-T-E-R-S. The Balters design, the vestibular wire goes into the buccal segment, so it acts like a Frankel shield. It's very, very nice. Because the biggest problem you have when you have settling of posterior teeth is the cheek infilling. So the Balters bionator is a beautiful nighttime appliance. It's very comfortable. The Americans tend to use a thing called a Damon splint. It's upper and lower vacuum retainer joined edge to edge position. I find that's very uncomfortable for patients to wear. With the bionator, I can adjust it and trim it and still encourage settling if I need to. But it keeps the muscles in the forward class 1 position, the corrected position.
Right, thank you.
Dr. Derek, the other choice for retention after class 2 correction, from your experience and from your opinion, what is the best methods for retention after class 2 correction?
Sorry, what was what? The time frame? I didn't miss that. Sorry.
After class 2 correction. Go ahead, Dr. Asher.
He said after correction of class 2, is there any other alternatives for retention?
No, you need something that's going to maintain arch width that you did, that's going to maintain AP, is going to maintain vertical and allow muscle remodeling. So really, there's only 2 appliances, bionator or well, Frankel. I mean, I don't use the Frankel, but Frankel had the same philosophy. So you can use a Frankel to a bionator, but the Americans tend to, they tend to use very much their standard Invisalign type retainers, right? What I'm saying is an average class 1 case, I can get away with fixed wires behind the upper and lowers and maybe upper Hawley, right? But in a class 2, you've got to retain what you've corrected and you've got to retain that muscle for a lot longer. That's why I have, the term is class 2 functional retainers. Yeah.
Yeah, thank you. Another question.
Doctor, I might only have time for one more question because I literally need to be somewhere after this.
Okay. I have only 2 questions from Dr. Sarah for long face. How do you intrude the molars?
Yeah, I like intruding. I trained at the Eastman and we used the high pull headgear with the cat whiskers bent upward. That still works, but compliance is a headache. Now we use one of 2 devices. One is from American Orthodontics. It's called a rapid molar intruder. You put a TPA in the upper, a lingual arch in the lower, and in between the molars, you have like a spring, but the spring is vertical. That works nicely. But what works even better is TADs. If you look at the research from Dr. Kim, and he's written the textbook on orthodontics orthodontic applications of microimplants, I put a TPA and then I put one TAD in the mid palate, like I think I showed you before. And then I can use something simple like power chain but the only thing is my TAD needs to have two little hooks. Sorry, the TPA needs to have two little hooks so I can put power chain from those hooks to the TAD, and that gives me very good intrusion. Yeah. So I prefer that.
But Dr. Derek, rapid molar intruder, coil spring sometimes fracture.
Exactly right. Yeah. So to me, although you can use it, and I have used it, I much prefer the TAD. The TAD is very predictable.
Yeah. Yeah. Thank you. The last question from Dr. Naif. How many millimeter we can get in different multifunctional appliance?
I'm not sure millimeters of what. I'm not sure that question.
Okay. 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 Finally, because it's time. Finally, this is on the screen. This is a certificate of appreciation from our university to you. So on behalf of Al-Azhar University, I receive this certificate of appreciation, and we hope to meet you physically, not only through internet. I know that it's a long distance from Australia to Egypt, but sure, we hope to meet you again after COVID-19 is finished, this pandemic is finished. And for you, we will print this certificate on papyrus paper, and we will send it to you. Yeah, from Egypt, and we will send it to you through one method of sending this certificate.
I've lectured in Egypt maybe 5 times now. I enjoy every. In fact, Dr. Zahir Abbas has organized All Going Well, or how do you say, Mashallah? Is that?
Mashallah, yes.
God willing. Mashallah in his Alexandria 2-year meeting, which was supposed to be, I think, later this year. So who knows? Maybe.
We hope. We hope so. We try to finish because it's time. And thank you, and we highly appreciating your effort with and I hope your lecture will benefit everyone on our time, on our webinar, on our platform. So thank you too much, Dr. Eric, and sorry, and I apologize for cannot catching you at the beginning of the lecture. Welcome. Thank you. Thank you.
Thank you, Ashraf, and thank you everyone for listening. I hope to see you all in Egypt very soon.
We hope for sixth time. We hope. Thank you.
Bye bye.
Thank you. Bye bye. See you. Bye bye.